Welcome to The Explainer. All right, today we're really going to do a deep dive, almost a university-level masterclass on headache. We're going to take what you'd find in a clinical neurology lecture and turn it into a really practical, structured way to think about diagnosis.
So here's how we're going to tackle this. We're going to walk through it just like you would in a real clinical setting. We'll start with the absolute first question you have to ask, then we'll break down the major headache types, and we'll wrap it all up with a case study that pulls everything together.
Okay, so when a patient walks in with a headache, your first job, the most critical decision you have to make, isn't figuring out what kind of headache it is.
Nope.
It's figuring out if this is dangerous.
And that one simple question, is it dangerous or not, frames everything you do next. And for our purposes today, when we say dangerous, what we're really talking about is a headache caused by increased intracranial tension, or ICT.
So you've got to be on the lookout for red flags, right? These are the signs that scream danger and mean you need to get imaging right away. For example, if someone over 55 gets a brand new headache, you have to think about giant cell arteriitis. Or if the headache is so bad it wakes them up from sleep at night, that is a really ominous sign of raised pressure inside the skull.
And this is exactly why being able to use an ophthalmoscopy is a non-negotiable skill. I mean, if you look in the back of the eye and see papilledema, that's a blurring of the optic disc, that's it. Game over. It's a definitive sign of danger, and that patient is getting neuroimaging, no questions asked.
Now, if that pressure gets critically high, it can start affecting the whole body. You might see something called Cushing's reflex. That's a really scary triad of high blood pressure, a slow heart rate, and weird breathing patterns. And why is this so scary? Because the ultimate fear with all this pressure is brain herniation. And the most common type, uncal herniation, shows up as a third nerve palsy that involves the pupil. That is a true lights and sirens neurological emergency.
Okay, so once we've done our due diligence and we're confident that this is not a dangerous, high-pressure headache, then we can start to think about the other stuff. The whole spectrum of benign, recurrent primary headaches. This table is a great high-yield way to compare the big three. First up, you've got tension-type headache. This is the most common one, that classic band-like pressure that's annoying but doesn't usually stop you from going about your day. Then there's migraine, the second most common, and the key word there is disabling. And finally, we have cluster headache. This one's way more common in men, and it's our classic example of a group we call the trigeminal autonomic cephalalgias, or TACs for short.
All right, let's zoom in on migraine now. It's a really complex neurovascular condition that actually happens in distinct phases.
Getting a handle on this progression is absolutely key to making the diagnosis. You see, for about 20% of people, they get what's called an aura before the headache hits. We call that classical migraine. The other 80% don't get an aura, and that's just called common migraine. And that classic visual aura with the zigzag lines, it's got a great name, fortification spectra.
You know, for a long time, we thought migraines were all about blood vessels or serotonin, and those ideas helped us develop the first treatments. But today, the science has really zeroed in on one key molecule, CGRP, or calcitonin gene-related peptide. This little thing is a powerful vasodilator, and it's a huge player in sending pain signals. So it makes perfect sense that it's become the main target for all the new modern therapies.
So, how do we treat an attack when it's happening? Well, this is what we call acute or abortive therapy, and we base it on how severe the attack is. For anything moderate to severe, triptans are really our go-to drugs. What they do see is they act as potent vasoconstrictors. They basically clamp down on those painfully dilated blood vessels in the brain, directly fighting what's causing the headache.
But what if the attacks are happening all the time, or they're just completely debilitating? That's when we think about prophylaxis, or preventative therapy. The goal here is just to have fewer attacks. We usually start with first-line stuff like propranolol or topiramate. But, and this is a big but, the real game changer has been the arrival of CGRP antagonists. These new drugs are amazing because they directly target that CGRP molecule we were just talking about. It's a massive leap forward from the older therapies.
Okay, let's switch gears to a really distinct group of headaches, the trigeminal autonomic cephalalgias, or the TACs. What defines these is this combination of severe, one-sided pain plus autonomic symptoms on that same side, things like a tearing eye or a stuffy nose.
Now, this table is super useful because it shows you exactly how to tell these apart. It's all about the timing, the duration, and frequency. And, this is really cool, the very specific treatments they respond to. So cluster headaches, the longest ones, are famous for stopping dead in their tracks with 100% oxygen.
paroxysmal hemicrania, has this incredibly dramatic response to a drug called indomethacin. It's almost diagnostic. And then you have SUNCT, which has way shorter but more frequent attacks, and you treat it completely differently.
Yeah, that quote really gets to the heart of it. The pain is just excruciating, this boring, drilling feeling right behind the eye. And here's a huge clinical clue. People with a cluster headache are agitated, they're restless, they're pacing around. It's the complete opposite of someone with a migraine who just wants to lie down in a quiet, dark room and not move.
Okay, this next point is absolutely critical. We have to be able to tell the attacks apart from their most common mimic, which is trigeminal neuralgia. And let me be clear, trigeminal neuralgia is not a TAC. So how do you tell them apart? It all comes down to the character and duration of the pain. Trigeminal neuralgia gives you these sudden bursts of electric shock-like pain. They only last for seconds, and they don't come with all those autonomic symptoms, the tearing, the congestion, that are the absolute hallmark of the TACs. All right, to wrap things up, let's pull all our ideas about those dangerous high-pressure headaches together with a classic case study. So, check out this vignette. Here you have a patient who is basically a walking, talking collection of all those red flags for increased intracranial pressure that we talked about right at the beginning. So what's the diagnosis? This is benign intracranial hypertension, which also goes by pseudotumor cerebri, or IIH. And the key thing to remember is that it's a diagnosis of exclusion. First, you have to get neuroimaging, an MRI and an MR venogram, to make sure there's no tumor or blood clot. Once that's clear, you do a lumbar puncture. And if the opening pressure is high, over 25 centimeters of water, and the fluid itself is normal, then you've got your diagnosis.
Yeah, that clinical triad is just classic for this condition. A daily, pressure-like headache, vision that temporarily blacks out, and a pulsing or whooshing sound in the ears. You see that in an obese young woman, and IIH should be at the top of your list.
Managing this is a step-by-step process. The absolute cornerstone is weight loss. At the same time, we use medication, usually acetazolamide, to help lower the production of cerebral spinal fluid. If that's not enough, we can move to procedures like repeated lumbar punctures to relieve pressure. And then, if things are really serious and vision is at risk, we have to consider surgery, things like optic nerve sheath fenestration or even shunting.
So let's circle all the way back to the beginning. We said papilledema is the surest sign of a dangerous headache. So what's the biggest risk if you miss it? Well, the whole point of managing any of these high-pressure headaches is to save the patient's vision. If you miss that papilledema, you miss the chance to step in and prevent permanent optic nerve damage. You miss the chance to prevent blindness, and that's really what's at stake.